understand me? Okay, thank you. Good morning, ladies and gentlemen. First of all, I would like to thank the organizers of this meeting for inviting me to present our work in the field of capsular endoscopy, and sorry for using my own computer, which always costs a little bit of time, but you cannot talk about endoscopy without showing videos, and therefore I have some videos linked. We've heard this morning earlier that there are several very frequent diseases that affect human life, and besides neurodegenerative disease, this is mainly also cancer. And the field I would like to talk about is the field of digestive cancers, and I'm a medical doctor myself. My background is experimental surgery, and digestive cancers mainly affecting the colon, but also the esophagus and the stomach, will affect about 15% of the overall population in developed countries. So it's a very emerging and very frequent problem, and our project is focusing upon technologies to detect those cancers very early and thus providing cure to patients at a very early stage. And if you look to those two images, this is exactly explaining the problem or the challenge that we are in medicine. You can see on the left side, on the left upper corner, a healthy colon, and down there a colonic cancer. And the time gap between those two images, not in this particular patient, but in general, is something like 10, maybe 20 years. So out of a very healthy bowel wall, benign disease develops called polyps. So it's a proliferation of the mucosa, which is primarily benign, but if not detected early enough and removed, this turns into a malignant and invasive cancer over time. Now the beauty of the beast is that this can be detected by endoscopy, very securely detected, and most countries sponsor screening endoscopy for the early detection of cancer. But only about 10% of the patients that are eligible for those screening programs make use of their right to have colonoscopy screening. And the main reason is that colonoscopy is perceived as a painful and uncomfortable procedure. And this limits the effectiveness of cancer prevention programs for the digestive cancer field significantly. We've made a survey among endoscopists across Europe and asked them what they feel are the most important reasons for patients not undergo endoscopy, endoscopic screening. And what you see here is that on a scale of 1 to 5, with a mean of 4.2, the most common cause was estimated the fear of pain. I don't know who of you had ever undergone a colonoscopy, but when we started this project, I had a colonoscopy being done on myself just to know what we are talking about. It's important to feel what you want to eliminate. And it is, I mean, it's not that bad, but it's not nice either. And well, you can survive. No, honestly, it is something that it doesn't spoil your day. So it's really, there is not a reason to, a rational reason not to have colonoscopy, but it's something that takes a commitment and is a step that is apparently difficult to make for many people. So stopping the pain associated with endoscopy means patients will undergo screening endoscopy more often. This means the incidence of digestive cancer will decrease, and that's the ultimate goal actually of our project. Now the idea of having painless endoscopes is not exactly new. It has been formulated decades ago with first ideas of having self-propelling endoscopes, because pain in endoscopy very much comes from pushing the endoscope inside the body of the patient, which causes force on the bowel. And first ideas were using tubings for transporting endoscopes. Then from Paolo Dario's group in Pisa, a self-locomoting inchworm type of endoscope that crawls without being pushed, crawls the digestive tract. So it's wired self-propelling endoscopes, and now more recently wireless endoscopes, making the advantages of capsular endoscopy available for also the colon and other sectors of the digestive tract, and the Vector project falls into that category. Now, is painless or is force reduction really something that we can achieve with self-locomoting or self-propelling endoscopes? And this is, again, the pioneering work that Paolo Dario and Arianna Menchassi and their team in Pisa have done with their first inchworm robotic endoscope. And this is the first really self-propelling endoscope that has been applied clinically now more recently by the spin-off company from Era Endoscopy from Scuola Sant'Anna in Pisa. And this is this device. So it has an optical front end with a chip, and it has this very flexible body. And what this flexible body does, it elongates pneumatically. And while it elongates, it can attach itself to the bowel wall here and here. And through this, like an inchworm, propel its body stepwise through the colon. And we have done tests on that, if this really reduces force. And we have used a test stand here into which we have installed a porcine bowel and compared conventional endoscopy, which you can see here, this is a conventional endoscope, with this inchworm endoscopy. And this is the force profile. So this is the force generated by conventional endoscopy, and what you see here are those force peaks. And this is when the endoscope passes the flexures of the bowel. This is where it hits the bowel wall, and this is what causes force peaks up to 4 or 5 newtons. Self-propelling endoscopy does not have that force profile, so we don't have those excessive peaks of force intake into the tissue. And this is reducing pain, and we use this very much as an analogy to support the idea of using even wireless capsules in the future, not like the one before, which is still wired, but wireless capsules like the capsule endoscopes that are nowadays used in small bowel diagnosis. So there are already capsule endoscopes on the market, but for small bowel diagnosis only. And we want to expand the reach of those wireless endoscopes to the entire digestive tract. And the consortium that is on this mission together with us is an excellent group of 18 partners from all over Europe and even South Korea on that mission. Now the idea is this the vector capsule. The idea is that the vector capsule has actually a locomotion system, actuators like in this example legs that allow it to move inside the digestive tract, enhanced diagnostic sensors for spectroscopy and ultrasound that improve diagnosis, and also a therapeutic and biopsy system to treat, because capsule endoscopes today cannot treat, they can only view and not do anything therapeutic. The target from a medical perspective is the entire GI tract. So our goal is to perform a total GI endoscopy with one device, a capsule that gets swallowed and can detect disease along the esophagus, the stomach, and the colon. Not so much the small intestine, because cancers of the small intestine are very infrequent. So we are after the cancer and not after other diseases. So this is why we don't target the small bowel so much. We are also focusing on upper GI endoscopy, which is, as the survey here shows, also an important modality, which is currently not clinically practiced very much, only in Japan. So we want to do that also with our project. Now, the locomotion side of the problem. We are currently evaluating 2 different approaches. One is an external magnetic guidance, which means an external magnetic field controlling the capsule inside, and the second are internal actuators of various kinds that allow the capsule moving inside with, like in this example, legs. Let me first show you the magnetic side, and what you see here is a video. This is a capsule that is magnetically controlled, so this is one of our prototypes. And now this is in a porcine bowel, in an ex vivo bowel, and you can see this capsule pulled through the bowel by an external magnetic field. And also important, it can also tilt its head, as you can see, to visualize the wall. A passive conventional capsule is just crawling through or rolling through the bowel passively. With this active magnetic control, we can, like in normal endoscopy, point the tip of the device towards the wall to visualize the wall of the bowel. So this is, has been a very important step for us, and in an ex vivo model we can travel the colon in something like 1 or 2 minutes. So this is very comparable to normal endoscopy. It doesn't work as well in vivo conditions yet, so we still have to do more work on that. Another challenge